everyone. Good evening and welcome to OrthoSouth's webinar on rotator cuff tears by Dr. Chris Pokabla. We will get started in just a few minutes, but I wanted to give you an overview of how our program will go tonight and apologize for being just a couple of minutes late. Thank you all for showing up. We will have everyone on mute this evening just so that we can keep background noise down while Dr. Pokabla does his presentation. If you have any questions throughout the presentation, feel free to enter those into your chat feature in Zoom, and then we will take and answer questions following Dr. Pokabla's presentation. A little bit about OrthoSouth. We have 6 clinic locations across the Mid-South. We have 2 surgery centers. We offer comprehensive orthopedic care and as well as physical therapy care. We have a 24/7 urgent care line that you can call, 901-261-STAT. So that's morning, noon, or night, Monday through Sunday, 24 hours a day. We also have evening hours at our Briarcrest location. That's from 5 p.m. to 8 p.m. And we do Saturday clinics from 9 a.m. to noon every Saturday at our Bartlett location.
No, cancel.
And if you do find yourself kind of coming off of mute, I will be, sometimes Zoom does like to play games with us a little bit, but I will be trying to get everything back on mute as we can. If you notice that you come off mute, please just hit your mute button again. And without further ado, I will let Dr. Pokabla here take it away.
All right. Well, we're sorry for the technical difficulties, but we're all together now, and I appreciate you guys all coming tonight for this Zoom presentation. I'm going to talk to you about all things rotator cuff tears. So let's get started. The first thing we're going to do is talk about the anatomy of the shoulder. And so your shoulder is made up of 3 separate bones. There's the humerus, which is the upper arm bone. There's the scapula, which is the shoulder blade, and then the clavicle, which is your collarbone. And the shoulder is a ball and socket joint. And you can see this picture here on the right shows all of the bones. Oops. And it also shows some of the muscles and tendons that are attached. So what is your rotator cuff? Well, it's actually a combination of 4 different tendons that help you lift and rotate your shoulder. Those 4 tendons are shown on the right, and they include the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. And the most commonly torn tendon is the supraspinatus tendon. And you can see that one is up at the top of the screen. So a rotator cuff tear occurs when the tendon is no longer fully attached to the head of the humerus. And there's 2 different types of tears. There's partial tears, which are incomplete, and then there's full thickness tears, which you can see on the right side of the screen. And this is a complete tear. The 2 types of causes are acute, and these are traumatic. And these usually occur in younger patients due to an injury, such as a fall on an outstretched hand, or when you fall and you hit your shoulder. The other type of tear is chronic or degenerative, and these are more common in older patients, and they're associated with bone spurs, repetitive trauma, and lack of blood supply. This video here shows a bone spur, and this is looking through an arthroscope, which is a very small camera inserted into the shoulder. You can see the rotator cuff tear below. And again, you can see the close proximity to the bone spur, which you're looking at right there, that sharp, jagged edge. So what are the risk factors? Well, we know that people over 40 are at greatest risk, and that's because there's normal wear and tear as we age. We also know that repetitive lifting or overhead activities put you at risk. And so athletes in particular, tennis players and baseball players are at greater risk, but also people that work overhead, such as painters, carpenters, and other occupations. Most tears in young adults, as we talked about earlier, are due to a traumatic injury, such as a fall. So what symptoms do patients experience? Well, the most common symptom overall is pain, and it's often localized to the outside or the lateral aspect of your shoulder. Activities that involve overhead range of motion may worsen your pain, and night pain is seen in many of these patients. Some of the other symptoms that are often seen include stiffness or limited range of motion, weakness, and then what we call mechanical symptoms. And this is when you feel a sensation of locking or grinding in your shoulder. So when should you see an orthopedic surgeon? Well, anytime you have an injury to your shoulder that causes significant pain or loss of function, such as inability to raise your arm, you should seek evaluation. The other time is if you have pain or weakness that doesn't go away after a period of rest or non-steroidal anti-inflammatory medications like Advil or Aleve. And then, of course, when you're referred by your primary care provider for evaluation. So what does the orthopedic evaluation consist of? Well, it starts with a history. And what the orthopedic surgeon will do is they'll ask you a few questions, including the onset, so when it began, and then the intensity of your symptoms, what factors alleviate or worsen your symptoms, any prior treatments, and we'll also review your general medical comorbidities. You will also take part in a physical exam. The orthopedic surgeon will visually inspect your shoulder. They'll palpate for points of tenderness, test range of motion, and of course, rotator cuff strength and atrophy. Additional tests are oftentimes performed to evaluate for other causes of shoulder pain as well during the exam. In this example on the right, you can see a patient who has significant atrophy of the rotator cuff when you compare the right side to the left side. X-rays are typically the first imaging study that are obtained by your orthopedic surgeon in the evaluation of shoulder pain, and they are used to evaluate the bones of your shoulder. So what we're looking for here are fractures, dislocations, or arthritis. The radiograph on the right shows a dislocated shoulder, so you can see that the ball is actually out of the socket in this image here. MRI, or magnetic resonance imaging, is also a test commonly used, and this is highly accurate, and it's used to diagnose rotator cuff tears. It not only tells you if you have a tear, but it will give you the location and the size of the tear. And more importantly, it helps us estimate the chronicity or the length of time that the tear has been around, because it shows us the quality of the rotator cuff muscles. If you look at this image on the right, this shows a rotator cuff tear. The white area to the right side of the screen where the arrow is marked shows you where the rotator cuff tear is located. So what about treatment goals and options? The goal of any treatment is to reduce pain and restore your function. And there are several different treatment options for rotator cuff tear. And the best option is different for every person. In planning your treatment, your doctor will consider your age, your activity level, your general health, and the type of tear that you have. Many patients can be treated successfully without surgery. Your surgeon may prescribe a period of rest and home exercise program, and this may help improve the range of motion and the strength of your shoulder. Non-steroidal anti-inflammatory medications, as you can see on the right, such as Aleve or Advil, are typically recommended. However, you have to remember to take them with food because of gastrointestinal side effects. Other patients may benefit from physical therapy. This is used to strengthen the rotator cuff muscles and also improve the range of motion. A steroid injection, which is used to decrease inflammation and pain, may be considered as well. This picture on the right shows what an injection looks like. The needle is advanced into the space between the humerus and the acromion, which is part of the scapula that we saw on our first slide of anatomy. and the steroid is injected into this little bursa, which is the purple area above the muscle and tendon. This video here is a subacromial steroid injection. This is one of my patients. It is performed in the office setting. Most patients experience very little pain, and evidence supports the use of a single injection of corticosteroid with local anesthetic for short-term improvements in both pain and function for patients with shoulder pain. You can see here we've used a topical anesthetic to help dull the pain. The needle is then advanced into the bursa. I check to make sure we're not into a blood vessel, and then the steroid is injected into the subacromial space. And then it's advanced back out. And that's the completion of the procedure. So what about operative treatment? Well, your orthopedic surgeon will determine if surgery is indicated for you and also discuss the risks and benefits with you. Surgery is typically performed in an ambulatory surgery center as an outpatient procedure. So this is a setting outside of a hospital where outpatient procedures are typically performed. Indications for surgery. Your doctor may recommend surgery if your pain does not improve with non-surgical methods, and continued pain is the main indication for surgery. Typically, your symptoms have lasted 6 to 12 months. You have a large tear, so that's greater than 3 centimeters, as seen on MRI, and the quality of the surrounding tissue is good. You have significant weakness and loss of function in your shoulder, or your tear was caused by a recent acute injury. So what are our options? Well, there's 4 main options, although there are certainly some others. But the main option that most patients undergo is arthroscopic rotator cuff repair. There is also a procedure called augmented rotator cuff repair, superior capsule reconstruction, and reverse shoulder arthroplasty. We'll talk a little bit about each one of these. So starting with arthroscopic rotator cuff repair, you've seen some of the images before, but essentially a small camera called an arthroscope, as you can see in the picture on the right, is inserted into the shoulder joint. And what the camera does is it displays on a video monitor, which you can also see at the top of the screen, and it helps your surgeon use small instruments, and it guides them while you're repairing the torn tendon. The advantage of arthroscopic rotator cuff repair is the very small incisions rather than the large incisions which were needed for open procedures in the past. And this typically results in less pain for patients, and importantly, it shortens the time to recovery and return to your favorite activities. This is a very short video clip of a rotator cuff repair. You can see here the tear in the tendon, which is below. And this small instrument is used to clean the bone so that it bleeds, and this aids in the repair. Here, a suture is being passed through the tendon. And you can see it's pulled through it, and this is going to be tightened down. This small instrument creates a hole in the bone in which an anchor is placed to secure the tendon. So you can see the anchor is now being inserted, and you can see the suture is tightened up. The anchor is then advanced down into the bone. And then it's essentially turned like a screw into the bone all the way down flush so that it is not prominent. And then the introducer, which is the blue device, is removed, and you can see the final repair with the tendon repaired. You no longer see that little hole. The next procedure is rotator cuff repair with augmentation. And we know that 2 of the things that are associated with failure of repair are poor tendon tissue and vascularity, which is the blood supply to the tendon. One option that can be used to aid in tendon healing is a bioinductive collagen scaffold. And one recent study demonstrated effective healing when treating very large and massive tears. And more importantly, many of the patients in this study, which was performed down at Tulane, where I trained during my fellowship, involved revision surgery. And this is typically the application that I see for the use of this. And I'm going to show you a short little video. So you can see the rotator cuff has already been repaired. And what you're doing here is introducing this bioinductive collagen scaffold above the rotator cuff repair. And now you can see it open up, and it essentially lays on top of it to help augment the repair. The third option that we talked about earlier is superior capsular reconstruction. And this is a newer treatment option. And it's indicated for relatively young patients with a tear that cannot be repaired. And this involves a soft tissue allograft, which is tissue from another person, and it is used to reconstruct the rotator cuff. So this is different from a repair. You're actually reconstructing the rotator cuff itself. Several recent studies demonstrate improved outcomes for many patients, although we certainly need longer follow-up. Here is a short video clip showing what it looks like. So the tissue that you can see on the left is the reconstructed allograft tissue, and it's incorporated into some of the native tissue where there was a defect previously. And it's very similar to a repair in terms of how it's tied down with suture anchors, and you can see the sutures right there, and also the native tissue adjacent. And then last is reverse shoulder arthroplasty. So this is a type of shoulder replacement that can be used to treat irreparable rotator cuff tears in older patients. And it's commonly used to treat chronic rotator cuff tears with arthritis. The ball and socket are reversed as shown in the x-ray. You can see on the right side of the screen the reverse shoulder replacement, and on the left side of the screen you can see the humeral head is subluxed superiorly, so it is above the socket because the rotator cuff is no longer there to hold it down. And this is a very effective procedure for patients that have rotator cuff tears with arthritis. What about rehabilitation? Well, most patients require a period of sling immobilization after their surgery, whether it's a rotator cuff repair, even up to a shoulder replacement. And this allows your rotator cuff to heal as well as the incision. Physical therapy helps patients regain their strength and range of motion. And we know that supervised physical therapy is more appropriate than unsupervised home exercises for some patients after rotator cuff repair. Moving on to biologics and regenerative medicine, there's been a lot of questions I commonly get from patients. So I'm going to just touch on a few of them. Biologic augmentation with platelet-derived products. There is limited evidence that supports the use of PRP or platelet-rich plasma in the context of decreasing re-tear rates in rotator cuff repairs. On the right is a picture from the American Academy of Orthopedic Surgery, which shows a vial that has undergone a centrifuge procedure. And this is essentially a machine that spins little tubes of fluid down, and it separates the different fluids within the blood. And you can see here the red blood cells go to the bottom, the white blood cells are in the middle, and then the platelet-rich area and the plasma are at the top. And so this is what is injected into your rotator cuff after it's repaired. Hyaluronic acid injections are also used, and there is limited evidence that supports the use of this in the non-surgical management of patients with rotator cuff pathology. And then finally, stem cells. There's two types that are available today. There are adipose-derived, which are from fat cells, and then there's bone marrow concentrate. And these can be harvested and prepared and then re-injected in the office setting. Autologous stem cells are obtained from you. So you're using your body's own cells and re-injecting them. There is one long-term study that showed significant benefit in rotator cuff surgery. However, certainly we need more studies to look at this new type of biologic procedure. I think, interestingly, on the right, a lot of patients have questions about what a stem cell is, and this is a nice demonstration. So it's a primitive type of cell that has several different type of functions. It can help reduce inflammation. It can fight cell death, which is called apoptosis. It self-replicates, and it can also differentiate into multiple tissues: muscle, bone, fat, and cartilage. So what are the take-home points? The shoulder is a ball and socket joint that requires the rotator cuff for many important movements. Rotator cuff tears can be acute, which are the traumatic type we talked about, or they can be chronic, degenerative type. Your orthopedic surgeon is best qualified to diagnose and treat rotator cuff tears. Non-surgical treatment benefits many patients by decreasing pain and improving their function and quality of life. Surgical treatment is a good option for patients with continued pain. Thank you for attending the webinar this evening. Any questions?
Hey, Dr. Pokabla, thank you so much. And actually, we do have some questions already. I just want to remind everybody that if you do have questions, feel free to enter them into the chat bar. And I will be asking these questions one by one to Dr. Pokabla. He will answer them for us. I have one question so far. When treating with a steroid injection, what circumstances would you decide not to inject? If you have a younger patient or an athlete, are you more conservative with injections?
So yeah, I'm actually really conservative with injections. And we know that there are some deleterious or negative aspects involving steroid injections. So I really do limit them. I'm not commonly giving them to younger patients, but I do think there's some benefit in the non-surgical management of some of our elderly patients where I'm not considering repair.
Excellent. Thank you. I have another question here. We did collect a few questions ahead of the webinar tonight. And this is a question about second tears and repairs. Has the procedure changed much for rotator cuff surgery since 2008? It used to be a pretty painful surgery. So has anything changed since then to improve the pain management and tolerance?
Yeah, so a lot of things have changed since 2008. The effectiveness not only of the anesthesia that is administered has changed. I think the blocks that are performed, so typically when I perform an arthroscopic surgery, the pain blocks that are performed provide excellent pain relief. We also have noticed with arthroscopic repair, there's definitely a decrease in pain compared to the larger open surgery that was performed in the past. And with the new use of some of these other procedures, we've seen certainly encouraging results early on, and we need longer term follow-up, but I'm excited about the future.
Thank you. I have another question here. Do the sutures stay forever, or does the body absorb them?
So when I do surgery, I don't use sutures that are non-absorbable. They're actually just resorbable. So I don't even have to take them out. If I do a rotator cuff repair, that's a great question, because patients will come in and say, don't I need to have my sutures out? And I say, no, you don't. We use absorbable sutures, and there's no need to take them out ever because we don't have to.
Excellent. Next is, how do you decide which of the 4 types of surgery to perform?
So I saw that question, and that's a great question. And it's based on several things. It's a little bit longer discussion, but essentially you look at the type of tear, the age of the patient, the chronicity, which involves looking at the MRI we looked at earlier. I showed you guys a picture. So if there's significant atrophy, that's a consideration. And then also the general activity level and the medical health of the patient help guide me into which type of procedure I'm going to perform.
Thank you. I'm going to jump back over real quick to one of the questions we received before the webinar. And it did ask, and we probably already covered this, if surgery is the only solution for a tear, and how long after an injury can you select surgery and obtain it as a complete fix?
So what was the first part? I'm sorry, I didn't hear.
Is surgery the only solution for a tear? And then how long after an injury do you have the option to select surgery?
So certainly surgery is definitely not the only option. About 80% of patients do relatively well in terms of pain and function without surgery. I try to focus on patients that have persistent pain despite non-surgical treatment. And then the second part of the question was, how long do you have? Is that what they asked?
The injury, can you select surgery and have a complete fix?
So every patient is different, as every tear is different, and patients also have different medical comorbidities. So there's no absolute in terms of how long. It's more of taking everything into consideration, the physical exam. If I see signs of chronicity in terms of their x-rays, if there's arthritis that's developed, if I see atrophy on exam, like I showed earlier in the picture, that will guide whether I can repair it or not. And also on MRI, looking at the amount of atrophy. So it's not just the tear itself, but it's those other things that I see, as well as the general medical condition of the patient that would decide that. So it's a good question, but it's a complex answer.
Thank you so much. What are some problems with steroid treatment?
So I've found that steroid treatment is overall relatively benign, although some patients have discomfort at the injection site. They can have changes in the pigmentation of the skin. There is a risk, very small but real, of infection after any type of steroid injection. And then also some patients typically will develop a little bit of warmth or irritation after the procedure is performed. And this typically goes away after a few days.
Thank you. If you think you have a tear, what should you do first? Advil, home exercise, see your primary care, and how long should you monitor your pain before seeing an orthopedic doctor?
So if you think you have a tear, I would try to see an orthopedic surgeon as soon as possible. And of course, that depends on the history. So if you've had a traumatic injury to your shoulder, you've fallen off a fence, or you were involved in a motor vehicle accident and you have significant shoulder pain, I wouldn't wait. I would get evaluated sooner than later, because we know if you wait and you do have a tear, there are some negative things that can happen, including tendon retraction and atrophy. And those can be very difficult to overcome even with surgery. So depending on the circumstance, now, if this is something that was an insidious onset, so no injury, just kind of woke up in the morning, felt some pain, and it's gotten worse, I would say a period of 4 to 6 weeks. If it doesn't go away, it's probably best to come in and get evaluated.
Thank you. Next question, has the reverse shoulder surgery changed? This is one of our OTs at Ortho South used to see that we would tell patients that if they got to 90 degrees of flexion, that would be considered successful. Now she's seeing that patients are gaining more around 130 to 140 degrees much faster. She's wondering if the technique has changed and the expectations after surgery.
So there have been some changes in terms of the procedure design, and that's getting pretty technical. But to answer the question, yes, there have been some changes which I think have advanced our understanding of a reverse shoulder arthroplasty, which is a reverse replacement. And some of those changes have definitely helped our patients in terms of range of motion. And also, I'm I think most surgeons are becoming more comfortable performing the procedure. If you look 10, 15 years ago, when I was a resident, I think I performed only 5 or 6 of those type procedures when I was a resident. It was not approved in the United States till the end of my residency. So it definitely has evolved in a positive way, which has benefited our patients tremendously.
Excellent, thank you. If a patient dislocated their shoulder and then they had a complete shoulder replacement surgery, and the patient is still having pain and they cannot raise their shoulder, what could they do?
So the patient has had a shoulder replacement after they dislocated the shoulder?
That's yes, yes.
And they're still having pain and cannot raise the shoulder. So I would be concerned about a potential rotator cuff tear, although there could be a variety of other things that are causing their symptoms. And that patient, it would be a guess for me to tell you over this webinar. They should definitely come in to see an orthopedic surgeon so we could get x-rays, do a good history and physical exam like we talked about earlier.
Okay, let's see here.
And that would help. That would also help guide what imaging studies we obtain too. So we'd have to do a more thorough evaluation.
Excellent. I have another question here. What are the symptoms again of a rotator cuff tear?
So the main symptom that we see is pain. But a lot of patients also experience weakness. So when they're trying to lift something overhead, they have a lot of difficulty with that. Limited range of motion is another common symptom. And then what we call mechanical symptoms, which is the catching and grinding that patients feel in their shoulder.
Excellent. I have someone here who says, I worked out after 9 months off due to COVID and decreased machine weight by 50%, but felt a problem on the bench press. Going down, the x-ray said that they had mild widening of the acromyoclavicular joint, suggestive of type 1 acromyoclavicular separation. What therapy or course of therapy is recommended in that case?
So again, this patient would probably need to come in for an evaluation. It sounds like they had an acromioclavicular sprain. A grade 1 separation is treated non-operatively. Patients often are prescribed non-steroidal anti-inflammatories. Many patients with this type of injury are given an injection into the acromioclavicular joint, which is very effective in pain relief. It's very rare for a patient to undergo surgery for this type of injury. But having said that, if their MRI was denied, there could also be damage to the rotator cuff, the biceps, the labrum. And if they've had physical therapy for 6 to 8 weeks, I would certainly obtain an MRI as well.
Excellent. Can you talk about how a rotator cuff tear can cause nerve pain down the arm and into the hand, especially the thumb, index, and middle fingers?
Yeah, so I commonly see that type of patient. They'll come in. I actually just saw one today with very similar symptoms. They came in and they said, I have shoulder pain and it's going all the way down my arm into my hand. They had numbness and tingling as well. And it's common to think that this is a rotator cuff tear or a shoulder injury. And some of the neurosurgeons will send me patients like that as well to look at, to make sure that it's not their shoulder, but typically it's due to the cervical spine. And so these patients will have a pinched nerve in their neck. And this is called cervical radiculopathy, but it's not due to the rotator cuff, those type of symptoms. But they can mimic it. And so that's why we do other tests during our physical exam and ask about this as well. And sometimes we obtain x-rays of the neck, which is what I did today. And it showed me arthritis in the cervical spine, which is the neck region.
After a diagnosis of a bone-on-bone arthritic shoulder, is it reasonable to image the rotator cuff to determine an injury could be a significant contributor to limited motion?
Yeah, I think it's very reasonable. I do that all the time. Yes.
And great. And if anybody else has final questions, we do have a few more minutes that we can answer them. I do have a comment here from Jesse Howard, who says, "Thank you for sharing your knowledge and expertise with us all."
Happy to. Those were all really good questions, by the way. All of those questions were good, I thought.
These are definitely great. Thank you all for being so engaging.
Yeah.
I have another question here. PT is physical therapy is telling someone that their shoulder problem is probably due to a trap muscle, so that therapy is mostly gaining strength with the trap. Does that sound correct?
So it's hard again to diagnose anything over a Zoom call, but certainly there are patients that have it sounds like a trapezius injury, which is a common shoulder injury that I see. Rhomboid, trapezius, periscapular muscles are oftentimes injured traumatically or due to repetitive activity, and physical therapists see this commonly. So again, I don't know, I'd have to look at this patient, but it's definitely something that's very reasonable and certainly occurs with regularity.
Excellent. I have a couple more questions.
Good question.
Is there anything we can do to protect against rotator cuff tears just in daily life? And who's at the most risk?
So just being in good general medical health will protect you from a lot of comorbidities. There are some studies that show increased cholesterol is associated with rotator cuff tears. So, sticking to a good diet, getting regular exercise and stretching. But oftentimes it's unavoidable. People that do a lot of repetitive overhead work, or people that unfortunately have a trauma and develop a rotator cuff tear, they didn't choose to do that. It's just something that happens, and we treat it and move forward.
Excellent. Is there any age group or activity level that's more at risk?
Yeah. So again, patients over 40 are at a higher risk, a different risk level than younger patients. That's the first thing, and then we know that certain sports, tennis, overhead, volleyball players have a higher risk because they're doing this demanding repetitive overhead exercise. Just like people that paint overhead, they're constantly having their hand over their head, and that causes repetitive stress on the rotator cuff. So those are the types of occupations and sports activities that cause it. And then was there a second part you asked, or was that?
I think that summed it up. Basically, kind of who was most at risk, or something of that nature with regard to activity level, age. And next, would you say that rotator cuff tears are the most common shoulder injury you see?
Yeah, in terms of injury, I would say yes. I also see a lot of patients with shoulder pain that is not a tear, but it's typically not an injury. It's more of an insidious onset, an onset without trauma. But if it's an injury, rotator cuff tears are probably the number one thing that I see in my practice. Now, my practice focuses mainly on the shoulder, so it's a little skewed in that regard. But I would say rotator cuff is number one, and then labrum, people that dislocate their shoulders, is probably number two. So yes.
Excellent. Does anybody else have any questions before we adjourn our webinar tonight? This has been excellent. Thank you, Dr. Pokabla, and thank you everybody for your for engagement. And if you do have any questions that were not answered today, or if we could not get to yours, I do have a couple that I'll be forwarding to Dr. Pokabla that he can, he may just say, yeah, I would need to see this patient in order to provide a more detailed response. If you have any other general questions, feel free to email them to mkandel@orthosouth.org. That's MKANDEL@orthosouth.org. And we'll be happy to forward those to Dr. Pokabla and see if we can get a nice general answer. Again, thank you all so much for your time. You can make appointments online at orthosouth.org or call us at 641-3000 anytime. And I'm sure Dr. Pokabla or any of our wonderful doctors here would be happy to see you.
Yep. Thank you guys very much for attending. Again, we have, like Melissa said, over 30 orthopedic surgeons that are trained in every subspecialty, whether it's the hand, wrist, foot, ankle, or even the shoulder, like we talked about tonight. And they're all excellent surgeons and wonderful people to work with. And certainly, if you have a shoulder problem, there's other providers too. They're excellent at Ortho South. If I'm out of the office, but we've got every other area covered as well. And I really appreciated all your questions tonight. Thank you for attending.
Thank you all.
Good night.